So with that, Susan, do you want to start?
Well, good afternoon, good morning. And body time, it is 8:20 in the morning, so it actually is morning rather than afternoon. I'd like to start by saying I'm really delighted to be here. I've learned a tremendous amount in the last couple of days, and I particularly want to thank Patsy and Amanda for setting the stage so thoroughly for my reflections on some of the DRI-related issues. So I won't apologize for wearing the DRI hat. DRIs are very near and dear to my heart. What I should perhaps apologize for is I failed art in kindergarten, and you'll notice that in some of the slides that follow. What I want to talk about, though, and revisit is the issue of requirement for what, the issue of requirements versus recommendations or recommended intakes, the issue of increased variability, upper levels and competing risks, and then the whole question of individualization. So one of the things in thinking about DRIs is people always talk about the requirement for a nutrient. And there are many requirements for any given nutrient, depending on what the selected indicator of adequacy is. We know it takes more vitamin C to nearly saturate neutrophils without having excess vitamin C in the urine than to prevent scurvy. So, requirement for what? This hasn't been terribly explicit in most of the DRIs to date, but there is one example, just to know that there are multiple requirements. The EAR for vitamin A for use in North America is set based on adequate liver stores. So 500 micrograms per day for women, 625 for men. But tucked away in the discussion in the DRI volume is a statement that for correction of impaired dark adaptation, the estimated average requirement would be 300 micrograms, and that might be appropriate in some other settings where perhaps vitamin A isn't as widely available. But the key, again, here is requirement for what? It will differ depending on what your outcome is. Then we ask about requirement for what in disease states. Are we looking for the requirement for the same indicator of adequacy as was used in the apparently healthy population? Or would it be a different indicator of adequacy that's somehow adversely affected by the disease? Or an indication of reduction of disease progression that acts through altered nutrient needs? Or ... down the line. So requirement for what is, I think, a really important issue. The next issue is the differentiation between requirements and recommended intakes. Nutrient requirements are for individuals. Even though these two puff people appear very similar, their nutrient requirements do differ. And the difficulty is that at this point, in most cases, individuals do not know their nutrient requirements, and it's very difficult for a clinician to determine what an individual's requirement is. We've seen this graph before. This is a distribution of requirements, emphasizing that different people have different requirements. There is a lot of individual variability, or as Patsy said, and I love this phrase, kinetics and dynamics and their modifiers and sensitizers. Some of them are listed here. And we can determine the average requirement, but that's only good for half the people. So if we're going to cover everyone, we'd like to have a recommendation that covers the needs of almost everyone. And that's set by adding what we know about the variability. So what happens in disease? If there's no disease, it's possible that the presence of disease could simply shift the position of the requirement distribution by a fixed amount. If in a given disease there was an impact on absorption and that impact was the same or the same proportion in everyone, then we'd simply shift the requirement distribution. However, it's probably much more likely that both the position and the variability of the requirement distribution may change. Now, I've shown this as shifting up. It could shift down, depending on which nutrient we're talking about. And that increased variability is due to all of the factors that everyone has been talking about: the disease severity, other comorbidities, inflammation, effective treatment, drugs, surgery, etc., and even variability within the person as the disease progresses or as they experience exacerbations and remissions. So we might have an RDA for the non-disease population here, and it could possibly be much, much higher if we were trying to cover almost everyone with the disease. So that then takes us to upper levels. And again, you've seen this slide multiple times. What has been emphasized to some extent is that there is a so-called safe range of intake between the RDA and the UL, where risk of not getting enough is low and potential risk of excess is also low. It's important to recognize that the magnitude of that safe range isn't constant across nutrients. So just as an example, for calcium in older adults, the upper level is less than twice the recommended intake, whereas for vitamin B6, the upper level is more than 75 times the recommended intake. So you saw with Amanda's slide that shrinking of that safe range, and that potentially could happen. So what does happen to upper levels in disease? It's possible that the upper level in a disease state might increase in parallel with the increase in the requirement. So for example, if you're thinking of the disease as reducing the absorption of a nutrient, so you need to eat more of that nutrient to allow the nutrient to have its biological function. But because you have to eat more to get a certain amount in, then you also would have to eat more than the normal upper level to reach the possible risk of adverse effect. On the other hand, the UL could stay the same, and that would occur if the UL reflected an indicator of excess that isn't affected by the disease. So a different mechanism for the risk of excess. And that brings us to the possibility of competing risks. If the disease shifts the requirement distribution to the right so that we need more to achieve adequacy, in this case, the recommendation for that group of people with the disease would probably be about there or above the upper level, and that would place a proportion of that group of people at risk of the adverse effect. So how do you manage those competing risks? Can we individualize? I think this is a really key question, because with all this heterogeneity, if we could somehow tailor things to an individual, that would be helpful. This grossly oversimplifies the need for the type of biomarker. It would need to be sensitive, specific, non-invasively obtained, inexpensive to assay, blah, 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 blah. But if that could be done, then one could perhaps titrate an individual's intake of the nutrient so that they could meet their requirement, because that biomarker could allow you to determine where they achieved the desired level. Possible example, serum 25-hydroxy-D. We think we know a level that meets the needs, at least for bone health as an outcome. So if somebody had CF and is malabsorbing vitamin D, we could use that as a biomarker to determine how much they needed and prevent them from getting too much. But we have a long way to go in biomarkers. I think progress will undoubtedly be made. The question is how quickly can we move there? So just to summarize the key points I wanted to bring up: requirement for what? Are we talking about requirements for individuals or recommendations for people with the disease, or even a subset of people with the disease with certain characteristics? How is the upper level affected, and how is that going to be dealt with? And can we individualize? So, thank you.